Hello, good morning, good afternoon, Dr. Tobias. Can you hear
Hello.
me?
Yeah, I can hear you very well. And can you hear me as well?
Absolutely, perfect.
Perfect.
Thank you.
That's good.
Th- Thank you very much for joining us. Everybody has been looking forward uh, to your talk. Let me just put on my face.
Hello. Good to see you.
Good to see you.
Hi.
Good to see you. I usually I'm a bit more prepared than this usually, but I had an appointment outside, so I'm coming back and rushing. We have about 16 people so far, 17 people
Yes.
waiting to join this. So thank you again for the accepting our invitation. And our audience really comes from the Middle East, comes from Asia, and a we have a lot of people also from Africa, even South America. And again, I have had a lot of people sending me messages that they're really looking forward to hear your talk. So I don't want to take more time than this. Again, thank you again, and it's your platform. You could go ahead and start your presentation.
Okay. Thank you very much. First of all, I would like to thank you for the invitation, and I'm happy to follow this invitation, of course. And just to be sure, I will give the talk, and then we have time for questions and answers, or how do you want to have it?
Absolutely. The total period is like 1 hour, so
Okay.
maybe 10 minutes at the end.
Okay, that's great. So I try now to share everything with you. Let's see. I hope that works.
So we see your email.
And now, do you?
No,
Oh no, not yet. Sorry about that. It's not good. I try to share it again. What about this one? Do you see the talk now?
Excellent, excellent.
That's
Yes, we
good.
do.
Okay. Okay. So, dear colleagues, dear ladies and gentlemen, once again, thank you very much for the invitation to give that talk on tinnitus. And the title was or is update on the workup and management of tinnitus. And I'm very happy to do that. And everybody who is interested in tinnitus is really very much welcome to share this. And I will start with a quick overview on what I wanted to tell you in the next hour. So I will start with some pathophysiology. I will keep that very basic, not too much information because there's a lot of neuroscience in the pathophysiology of tinnitus and a lot of different models, and we don't want to go too much into detail with that because I assume that most of you are practitioners, clinicians, otologists, and not so much neuroscientists. I will tell you some basics about tinnitus. I will, of course, talk about the multidisciplinary approach in organizing a good tinnitus therapy, and I would like to focus on the role of the otolaryngologist in that setting. I will tell you something about tinnitus assessment and therapy. Of course, this might go in hand with each other, and maybe we start with some assessment, go to some therapy, start with some assessment again, and go to therapy. I'm very much involved into tinnitus research, and that's the reason why I would like to tell you at least at the end something about neuromodulation of tinnitus. And then at the end, as we discussed before, I will be happy to answer questions. And if somebody doesn't want to do it online with Zoom, we can also do it by email, of course. So some very basic information on tinnitus. As you all know, tinnitus is quite frequently associated with sensory neural hearing loss, as you can see here in the short audiogram. It's usually high frequency hearing loss, but it can be all types of hearing loss which are associated with the perception of tinnitus. Usually when we look inside the ear of the patient, we don't see very much in most of the patients. Of course, sometimes we see special findings in the otologic examination with the oto microscope, but not in the main field. And what is interesting, and I think what leads us a little bit into tinnitus pathophysiology, is that you might all be aware of that tinnitus is persisting even after dissection of the auditory nerve or of the vestibular auditory nerve, which we sometimes find in patients with vestibular schwannoma. When we dissect the nerve and the tumor, and the patient is deaf afterwards, then usually tinnitus is not disappearing in that situation. All our knowledge of tinnitus pathophysiology usually comes from neuroimaging, and we have different methods of neuroimaging up to date now, especially in structural and functional mode. So we have functional MRI, structural MRI, we have different kinds of PET scans, we have the EEG and the MEG, and if we use these methods in tinnitus patients, we really see changes in the central auditory system after the loss or change of input from the ear. For example, by functional resonance imaging, you can see activity changes in the area of the brainstem, here in the area of the dorsal cochlear nucleus, in the area of the inferior colliculus, in the medial geniculate body in the thalamus. And if you use PET scans, you can also see changes in the auditory cortex, like here, hyperactivity in the left auditory cortex. And if you use EEG or MEG scans, then you can also see changes in the auditory cortex. For example, this very important work here by Mühlnickel from 1996, which could demonstrate a tonotopy shift in tinnitus patients here in the area, for example, of 6,000 hertz. In all days clinical life, we don't have these sophisticated measures. Unfortunately, they are not available because they are very sophisticated to perform and very expensive. Here we have the audiogram, of course. As I said before, we see some changes, especially in the high frequency area. For example, here on the right side, we can also do otoacoustic measurements where we can see some changes if we compare tinnitus patients with non-tinnitus patients. We have the structural MRI scan where we can detect structural changes in the cochlea, in the internal auditory canal, or like here in the cerebellopontine angle, like here in that case with the vestibular schwannoma. But that's usually it. So we don't have much more what we can do in our patients. With the next models here, I would just like to let you know there is an idea how tinnitus arises in the brain, especially because it is obvious that changes of the auditory input into the brain are followed by compensatory mechanisms in central auditory structures. So usually we have the hearing loss first, we have a loss of input, and then we see changes on the central nerve system level, usually in terms of hyperactivity, but it's not limited to the auditory brain. We have changes also in non-auditory brain structures, and there are now different models by several authors, which I have listed here. I don't want to go too much into detail with that. We have the very first model of Pavel Jastrebov. You might be aware of Pavel Jastrebov. He is more or less the founder of modern tinnitus. He developed the neurophysiological model and developed a type of therapy which is still here under the name of tinnitus retraining therapy. We have the thalamocortical dysrhythmia model by Linas. We have by Dirk de Ridder a model which is called the global brain network model. We have by Joseph Rauschecker from the US a Rauschecker gating model. And very recent, it's Will Sadley who invented some new models. One of them is called the integrative tinnitus model based on sensory precision. So a lot of different models which are more or less summarized in that publication here. And I think for you, it's important to know that at the beginning of most of the tinnitus stories, there is a change of the loss of the change of the input, usually in terms of loss of input. This leads to some changes in the auditory cortex, but this is not the story alone. So it needs to come to some changes also in non-auditory areas, which are responsible for different things like attention, conscious perception, emotion, distress, memory. You all know that the emotional brain is here located in the limbic system. We have memory areas in the parahippocampus. We have attention networks here in the dorsal lateral prefrontal cortex and the parietal cortex. And only this networking, these going together of different brain areas at the end comes to the functional perception of tinnitus in the single individual. Here is a very nice video which I would like to share with you because it summarizes very well all we know about tinnitus pathophysiology, and it does it pretty much better than I do with my words. I will start that for you now and hope that you can listen to it. I changed something with the tone.
In the UK, 6 million people experience sounds for which there's no external source. These people have tinnitus. The symptoms of tinnitus are often described as ringing, buzzing, or whistling sounds that are perceived within the ears or the head. However, it's not the ear that's responsible. Instead, the causes for tinnitus can be found in the brain. The brain is made up of a huge number of active nerve areas which all have different roles. Sound information is processed via a very specific brain area known as the auditory cortex. The auditory cortex is divided up into areas that are responsible for processing different pitches in a similar way in which keys would be arranged on a piano. Anything which causes us to lose our hearing can have the effect of disrupting this internal keyboard. This could be caused by medication, loud noises, or just the natural aging process. Due to this disruption, there's a reduction of activity in the keyboard areas affected by hearing loss, and the nerves that make up the area can start to fire spontaneously. This is called neural synchronization. Or to put it another way, if the ear no longer talks to the auditory center, then the nerve cells in the auditory center begin to chatter in an overactive and unregulated way. It's this abnormal overactivity which causes us to perceive the tinnitus signal. Over time, this abnormal activity becomes permanent. Modern imaging procedures enable us to see evidence of the abnormal neural synchrony within the auditory part of the brain. This abnormal neural synchrony doesn't remain limited to the auditory center. Brainwave measurements have shown that brain areas regulating attention, emotions, and stress are also affected. The faulty signals in all these areas together allow the tinnitus tone to invade into our consciousness. This interaction of brain areas influences the individual level of distress and anxiety experienced by each person, as well as the perceived volume and invasiveness of the tinnitus.
This video helps us very much to understand how tinnitus is developing, and probably is a nice summary of everything which I tried to tell you before with some different words. So there's one specific entity of tinnitus which I would like to tell you in addition. It is called somatosensory or somatic tinnitus, and this one is based on the observation that somatosensory information from the cervical spine or jaw area causes or changes a patient's tinnitus perception. As you can see here, it occurs quite frequently. Only a third of subjective tinnitus patients are not experiencing it, while the other 2/3 have it to a certain extent at least. Here is the structural anatomical reason for that issue. On the level of the brainstem, there is an interference of nerve areas of the somatosensory areas with the auditory system in the area of the dorsal cochlear nucleus. Some basics on tinnitus. So first of all, tinnitus is very frequent. We think that around 15% of the population is affected worldwide, I would say. If we look at numbers from America, then we have 36 million of Americans affected. We have 12 million Americans severely impaired by the perception of tinnitus. Usually we have more male than female. This might be related to the degree of hearing loss, which is usually more extended in male patients, maybe due to work or noise experience. We're not quite sure about that. Quite interesting, the left ear is more affected than the right ear. I can't tell you the clear reason for that. We have a vast amount of people with hearing loss among tinnitus patients. We have some patients with normal hearing in the mid ages or in the early adolescence or in the kid even. But there are some models, even in that situation. You might have heard about the hidden hearing loss model or the cochlear synaptopathy model, which are explaining why even with a peripheral normal hearing, you can also experience tinnitus due to that models. According to the hearing loss, we have the highest prevalence in the second part of life, starting with the 50s. It's a most prevalent problem for war veterans, probably due to noise and distress. We differentiate in between acute and chronic tinnitus. Acute is usually until 3, or from the literature in some publications up to 6 months, and everything above that is chronic. It's not a very important issue in my eyes for the affected subject, but for the patient who is going to treat, for the doctor who is going to treat the patient. We differentiate in between subjective and objective types of tinnitus. Much more frequent is the subjective type, but we have some objective type of tinnitus, which I will show you later, which are important to recognize them, because in these areas, you sometimes can really do something like treating the patients in terms of healing. And so this is an important task for us otologists to detect these very specific subgroup of tinnitus patients. How should an ideal clinic for tinnitus patients look like, or how should it be organized in a tertiary referral center? I think that according to the complex pathophysiology, it should be clear that a multidisciplinary structure is of utmost importance. In the pole position, you see the otologist, the audiologist, of course, depending on the different medical systems in different countries. It depends, for example, in my part of Europe, it's more the otologist. In the Anglo-American part, it's maybe also the audiologist who is taking the primary point of contact for these patients. But then the other most important partner really should be found in the fields of psychiatry and psychotherapy. Other partners might be involved with respect to the single subject's history. For example, the dentist, according to jaw problems, the physiotherapist for the jaw and the neck, of course, the psychologist, if he's doing psychotherapy, sometimes we need pictures, and not so much involved, at least in my experience, are neurologists or neurosurgeons. So if you have a multidisciplinary tinnitus clinic at your department, I think the otologist is very important. He should try to identify an interested audiologist and, of course, an interested psychiatrist and psychologist. And in an ideal situation, the chronic tinnitus patients with subjective tinnitus should be seen at the first consultation at these core facilities. After you have seen the patient, you can discuss it with your colleagues in terms of a small basic, let's say, conference at the end of the clinic, and further evaluate a diagnostic and therapeutic plan for the patient. And maybe you decide to enroll other disciplines like dentists, physiotherapists, and so on. But at least in my point of view, the otologist should fulfill the coordinating role as a monitor and follow the patient on a regular basis, and maybe modify the management plan as needed. If you want to have a pragmatic approach, there are some measures which are really basic, but there are a lot of investigations which should be adapted to the single patient and to the involvement of the respective discipline. Here's the part of the otologist. Then we have the audiologist, neurologist, neurosurgeon, psychiatrist, psychotherapist, and so on. And flowcharts are sometimes helpful, especially at the beginning. And this is one example of the Tinnitus Research initiative, which is available for free in the internet and which you can have a look at. And if you go to the single boxes, then other boxes open up and it's very interactive. So I really can recommend this flowchart to you. And we have different guidelines from different institutions and societies. You might be aware of the guidelines from the American Academy of Otolaryngology Head and Neck Surgery, which was first published in 2014. And there are some others from the European teams. There is one from the UK, which are quite helpful and have a good source of evidence-based knowledge in the field. So again, the otolaryngologist is very important in point as the first contact for the tinnitus patients, depending on the system, of course. And that's the reason why I think that every otolaryngologist should at least acquire basic understanding of tinnitus pathophysiology, because the first contact is very, very important. And it's important because you can do a lot of good things in that first contact, but you can also do wrong things, which lead everything in a completely false direction and create a strong tinnitus career of the affected individual if you do it in the wrong way. It's important to differentiate in between acute and chronic, subjective and objective. And the core competence of the otologist is to detect underlying otological causes and somatic diseases. The starting point, of course, is the history. You want to know something about the circumstances of onset. You want to know from the patients if it's a pulsatile or non-pulsatile type of tinnitus, if there's some vertigo in addition to the tinnitus, and of course some hearing loss, ear pain, oral fullness, otorrhea, ear surgery in the back history, or some sinonasal problems, and so on and so forth. And you might be interested as well in the psychosocial background, because this is important, especially for the development of, for example, a decompensated type of tinnitus. And in my eyes, it's very important to empathize with the patients and take him really serious in order to bring everything forward into a good way. It's very important to avoid catastrophic statements, as I said before. Statements like, oh, I cannot do anything for you. You need to take care of yourself. It's a problem which we can solve. There's no therapy for tinnitus, or it might even be a tumor behind this symptom. So these are bad statements which create big amount of problems for some of the affected individuals. In order to assess the degree of suffering, there are additional questionnaires which are quite helpful. There's, for example, the Tinnitus Functional Index, which is pretty good to detect treatment-related changes. We have the Tinnitus Handicap Inventory. It's probably the internationally most widely accepted tinnitus questionnaire. It's validated for the most frequent languages, and at the end you receive a score which can be graded into a certain handicap of tinnitus perception. You can see it here. Grade 1 to 3 is considered to reflect a compensated situation, whereas grade 4 and grade 5 is indicated decompensation. And there you know pretty much if you should involve or should not involve psychiatrists or psychologists. And if that's too complicated for you, there's also a more simple form of evaluating tinnitus severity, like is demonstrated here in that flow chart. It's very easy. Is your tinnitus annoying or not? No impairment. If you say no, it's a compensated tinnitus, clearly. If it has some major negative consequences on your daily life, no, but some slight impairment, sometimes annoying in defined conditions, e.g. In quiet environment in the evening, or in stressful situations, or when it's getting very silent, then it might create some impairment. That's great too. If you answer this question with a yes, then you should go further and ask the patient, are you still able to do your work? Can you do your housework? Can you take care of your family, your kids, and so on? If he says no, then you really have a big problem in terms of a severe impairment with severe disturbances in private and working life, which is then considered to be a grade 4. And if he says, nah, yes, I can partly take care of all these things, but it is a permanent annoyance for me with some disturbances in private and professional areas, you might consider that as a grade 3, which also is in part a decompensated situation and needs some professional management after that. Usually you have to look in the ears first. We use the auto microscope in my clinic. Usually we see that here, but sometimes you are happy and see some wax and take the wax out and everything is solved, but this is only occurring very rarely, to be honest. Sometimes we find special things. A patient is coming with a history of tinnitus as the major complaint, but you see maybe a developing cholesteatoma, or you might see some bony exostoses, or you might even see a trauma. Probably you know the history of the patient a little better than that. You might detect a hole in the tympanic membrane, which is also, of course, inducing hearing loss, and on this way can, of course, induce tinnitus as well. There are some patients where you might discuss surgery, and when the patient is coming with the primary complaint of tinnitus, the patient might ask you on the prognosis for the tinnitus if you discuss surgery with him. And sometimes it's not that easy to give a good prognosis, especially in terms of tympanoplasty. If you perform tympanoplasty, then it's quite clear that you can't tell the patient exactly what happens to the tinnitus after a successful surgery. So you can tell him only, listen, for a third, it might become better in terms of partial or complete remission. For another third, there might be no change. And for another third, at the end, it might even become worse. It looks better for the situation of stapes surgery in my eyes. We have some reviews and some studies where the researchers looked for the complaint of tinnitus before and after surgery. And I think here it's quite clear that you can offer the patient the good chance to get at least partial or even complete remission after surgery. I would say in most of these studies, you can tell them at least for 2/3 of patients, let's say 60 to 70%, we have an improvement of tinnitus perception, but in 1/3 it might stay the same or even become worse. If there's pulsating tinnitus, we have two options. One of the vascular origin, where I think it's quite helpful to perform auscultation, maybe even ultrasound, because you can use it for the occlusion of the internal jugular vein. And then if the vein is occluded and the patient is not perceiving the tinnitus anymore, then you can be quite sure that it's of a venous origin. Usually MRI and CT scans should be performed in that situation. I usually go for an MRI angiography in patients with pulse synchronous tinnitus in order to rule out any problems with the vessels. And the direct subtraction angiography is only for cases where you can really do any type of invasional procedure via the catheter in the vessels. You know that we can sometimes see glomus jugulare tumors by the movement of the tympanic membrane, like here in that case, or we might see an apparent internal carotid artery, or we can see a glomus tympanicum tumor. So there are something which we can see directly with the otomicroscope, but for most of the cases, we need additional neuroimaging or auscultation and ultrasound in order to come to the right diagnosis. Another possibility is a fistula. Usually these are arteriovenous fistula. They come after traumas or after surgical interventions with opening of the skull. Here, for example, a fistula in between the sigmoid sinus and the occipital artery, which is causing a pulse synchronous tinnitus. And if you palpate here behind the ear, you can usually feel the fistula. And if you use auscultation, you can also hear it. And this is a typical case for an intervention of a neuroradiologist. As I said before, for some types of these objective tinnitus, especially of vascular origin, we can do some really solving therapies in terms of interventional neuroradiology. They can place stents or coils at the exact positions. And then after the intervention, the tinnitus is usually gone. For some cases of carotid stenosis or carotid dissection, vascular surgery can be indicated. And of course, for the glomus tumors, aneurysms, and so on and so forth, which probably are the reason, if you can find them for the pulsating tinnitus, then otoneurosurgery is indicated. On the other hand side of pulsatile tinnitus, we have the tinnitus which comes from muscle movements. Usually these are myoclony, which can come from the palate, or which can come from the middle muscles. You know all about the stapedial muscle and the tensor tympani muscle. If these muscles get spasms, then these spasms can be heard. For the palate, and it's quite clear because these palatal muscles are inserting in the eustachian tube and or alongside the eustachian tube, and then the movements, of course, can be transferred via the eustachian tube to the middle ear and to the cochlea. If you use your iPhone, in some cases you can even hear the clicking sounds. I try to play them for you. It needs to be very silent, but listen to that small sound file here. With an iPhone in front of the patient's ear, and you can hear these pulsating clicks, not that rhythmical like the pulse synchronous sounds of the vessels, but sometimes it can be heard. And if you're very lucky, then you can even see them with a tympanogram. If you do a long run tympanogram, then you can see the movements of the tympanic membranes, which are associated with spasms of the tensor tympani or the stapedial muscle. Another thing which is really easy is to just have a look inside the mouth, and then you can see the palate moving. And this is synchronous to the clicking perception of the patient. In terms of therapy, you have different possibilities. You can use medication in terms of anticonvulsants and muscle relaxants. You can use magnesium, but in my eyes, the most helpful substance is Botox, especially in terms of these palatal myoclony. You can just inject Botox. For example, usually I start with 10 units placed on 2 locations here in the soft palate. Usually I combine the injection needle with an electromyogram, and then I know from the sound of the needle when I inject here that I'm in the right place. And usually I start with 10 units here and 10 units there. After palpation with the finger in the palate, this works quite well. And in only really very rare cases where you can really be sure that the myoclonus comes from one of these muscles, then you might discuss the cutting of these tendons of the muscles. As I said before, we have this very special type of somatosensory tinnitus. And when the history shows that at least one of the following occurrences was there prior to the onset of tinnitus, I think you should think about at least a part of the tinnitus coming from that area. If you have head or neck trauma, if you can modulate the tinnitus by movements of the teeth, jaw, or the cervical spine, if you have recurrent pain episodes in that areas, if there's a temporal coincidence of appearance, an increase of both pain and tinnitus, if the increase of tinnitus is related to different postures, like example, lying down during sleep, walking, working, doing special positions of the head and neck, then this might be obvious that there is a relationship in between these two systems, the somatosensory system and the auditory system. And of course, I always ask for bruxism during day or night time. If it's quite obvious that we have an interference in between the two systems, you can also look at it as an otolaryngologist. This is, I think, quite simple to do that. You see here on that slide some different movements which you can ask the patient to do himself, or you press to some of these muscles even inside the mouth if you want to palpate the pterygoid muscles, and which might induce some pain and even some increase of tinnitus. And in order to do this, it is helpful to do it in a silent chamber, because then the patient really can listen to the development of its tinnitus and tell you if it's getting louder or even more silent than before. Here are some others of these maneuvers, which can really be done also by an otolaryngologist. And if you find something there, it might be for you the consequence that you send him to a physiotherapist or to a dentist for further specific assessment and therapy in terms of physiotherapy or dental splints, for example. It might be interesting to know what type of audiological measurements should be done in a standard tinnitus patient. That's not that easy to ask or to answer these questions because you have a high different possibility of measurements, like you can see them here. And what I usually do as a basic measurement is, of course, the Puton audiometry in between 125 and 8K. Depending on the age, I include one of these two measures, either speech audiometry or the ultra high frequency audiometry. This is really very much depending on the age. In a young patient, let's say below 50, for example, I would consider this as an adequate measurement. And if it's an older patient, then I want to have the speech audiometry instead of that, because here you can be sure that the ultra high frequencies are not that good represented anymore. I usually do loudness and pitch match. This is for academic reasons, of course, but usually it's also quite helpful for the counseling of the patient, because usually you find quite a good correlation of the pitch match and the area of the highest degree of hearing loss in the audiogram. And that helps you to tell the patient the story why he has tinnitus in that specific situation. What is the consequence of audiologic assessment? Of course, it's, as I said just before, it's supporting you in informing the patient for counseling. You can tell him, listen, the tinnitus has this and that reason. Especially, it helps you to understand that hearing loss is the first step and listening to a tinnitus is the second step. So it's a predisposition to have tinnitus that you have hearing loss. So you come from the somatic side and then go to the central nerve system in order to explain the patient why he has tinnitus. In case of asymmetric hearing loss with tinnitus on the worst side, I usually want to have a clarification of retrocochlear lesions, and then I do an MRI scan. I don't do any auditory brainstem measurements in that situation anymore, because there is a high degree of missing small vestibular schwannomas, for example, and you have the better situation with the MRI scan. It's helping you in looking for the right sound therapy in specific patients, of course. Hearing aids are very much recommended by the AAO guidelines, and usually I'm very much in favor for hearing aids in special hearing situations. If the patients qualify for that, then I recommend the use of hearing aids. If the patient is deaf on one side, you can of course go for cochlear implantation, especially in the situation of single-sided deafness. There are some very good data for that, which support that cochlear implants are even the best therapy for tinnitus we have, because here you have the highest amount of success of around 80% suppression in the bilateral deaf and even in the single deaf situation. Noise generators are an option. We have different types of other sound therapy, neuromonics, coordinated reset neuromodulation, the tailored notched music therapy, etc., etc. Unfortunately, there's no clear scientific evidence for these specific types of sound therapy. So usually I are not in favor for these things here. They are usually quite cost intensive, and sometimes it just helps you to distract your focus from the tinnitus if you ask the patient to use a radio, to use natural sounds, to use smartphone applications which you can get for free on your smartphone, and so on and so forth. And as I said before, the pitch and loudness measures are important for counseling, but sometimes you can even measure treatment effects if one of these criteria is changing. Here's a special situation, and it's an explanation why I like very much the ultra high frequency audiometry. You can see in the normal audiogram, you would miss that hearing loss in the ultra high frequencies. And as I said before, usually the place where you see the highest amount of hearing loss is the place where you can also do the pitch match of the tinnitus in that situation. And so this is very helpful, especially for the counseling of young patients. A few words on tinnitus and cochlear implantation. As I said before, it's the best therapy we have. We have reviews, as you can see here, which are summarizing some studies. Here's a review on the bilateral hearing loss situation, which is qualifying for the use of cochlear implantation. And you can see that here it has a very good effect in the tinnitus situation. All studies demonstrate improvement of the post-operative score. Quite sometimes there's even quite a substantial amount of reduction in the tinnitus scores, as you can see, for example, in that situation here or in that situation here. So for the counseling of these patients, you can be quite positive and tell them if you use the cochlear implant during it's on, then usually the tinnitus is suppressed and it only comes back when you put it away at night. You may have even some part of residual inhibition after you put away the cochlear implant, which helps you to fall into sleep, and then it comes back when you wake up in the morning. But as far as you put on the cochlear implant, then usually the tinnitus is gone away again. Hearing aids and tinnitus management, some words about that. According to the tinnitus etiology, loss of input is the most important step. So enhancement of auditory input should be helpful. And according to a review of Shekhawat, at least partial restoration of input should help to reduce the central gain in auditory perception. And he's stating that the majority of studies reviewed support the use of hearing aids for tinnitus management, and clinicians should feel reassured that some evidence shows support for the use of hearing aids for treating tinnitus. To be honest, the studies are not very good, and usually you don't have a clear control group for that. But however, this review identified 11 studies which were included in the systematic reviews. And you can see here that in most of the situations we see in up to 10 of 11 studies some improvement, and up to 50% reduction in tinnitus severity was observed, especially in these two studies where they used the tinnitus handicap inventory. You can see up to 50% of reduction in the tinnitus severity score. As I said before, additional sound therapy might be helpful for some patients. The classical situation is that the patients cannot fall into sleep because they always listen to the tinnitus, and then the distraction of the focus is quite helpful. And usually I tell the patient, listen, there are some possibilities, and take whatever you want and take whatever is pleasant for you. And if somebody tells, I can sleep the best with the television on, which is then going off in an hour, then it's fine with me. Classical noise generators don't play a role as in the late 90s when tinnitus retraining therapy was invented and we didn't have smartphones and things like that. Background noises might be helpful, natural sounds, open the windows to listen to street traffic, etc. An indoor fountain is an option, music is an option, smartphone applications, as I said before, for example, here of the Phonak company, they have a version for free, the Tinnitus Balance app. There you can differentiate or choose in between different types of noises, rain, waves, wind noises. The specific sound therapy, which is oriented to the tinnitus frequency, I think there is no good scientific study which really supports the value of that it's more effective than one of these other things. So usually I am not recommending these things. And at the end, the best is whatever helps you most. So please feel free to try. Counseling, some words about that. It's the most important step of tinnitus therapy in my eyes. It's recommended by the AAO guidelines, and it should help the patient to collect some information about the tinnitus, and it should help to avoid catastrophizing attempts of the affected individual. tinnitus is not dangerous should be one of the key messages. It's not the problem, but the reaction on the tinnitus might be the problem for you. And it's very important to know that most people learn to habituate to the tinnitus situation. It's not necessary that the tinnitus goes away, but you will be able to have a normal life with your tinnitus. And the quality of life should be much, much better after counseling, after other types of therapy. Psychoeducation is very important to tell the patient about tinnitus generation and deliver some strategies for destruction, as we've discussed before, masking techniques, relaxation techniques, etc. Inform the patient about further therapeutic options he has. Provide hope is very important, and necessary to know for you that some parts of this counseling can also be provided on a group level. So in our hospital, we have a psychoeducation group, which we do together with our colleagues from the Department of Psychiatry and Psychotherapy, where we collect some patients together and then develop in several sessions information on tinnitus. Here are all the different management options, which I usually discuss with the patient. On this side, here is more the ENT part. On the other side, here is the psychiatry part. You can see that hearing improvement is a key part for the otolaryngologist. Choose the right sound therapy, do counseling, maybe some drugs. You know that there is no specific drug which can be added to the portfolio, but we have some drugs which at least help the patients. I will have some words on that later on. Of course, the somatosensory treatment can be taken into consideration in terms of physiotherapy, dental splints, etc. And the basic role of the psychiatrist and psychotherapist is, of course, here in the part of cognitive behavioral therapy. That's not an issue which can be solved by the otologist himself. And neuromodulation is at some centers an option, but it's still experimental, it's research. I will give you some words on that later on. Here's the situation of the psychiatrist. I just want to give you a small insight in that. It can be very helpful to ask all these questions on hyperacusis, loss of concentration, exhaustion, continuous emotional distress. This can all be related to tinnitus, and you know that there is quite an overlap on tinnitus and depression, tinnitus and anxiety, sleep disturbances in terms of tinnitus, depression, and anxiety, the suicidal risk. And I want to tell you that if you don't ask for it, then the patient will not tell you. And even as an otologist, you are able to ask about these questions. And if you get clear answers on that, then you should not hesitate and ask a psychiatrist for help in that situation, and be quite clear to the patient and tell him on the well-known overlaps in between these different comorbidities and tinnitus. The most or the biggest evidence in literature for any type of chronic tinnitus therapy, especially in the chronic subjective type, is delivered by studies on cognitive behavioral therapy. This could even be documented in the very recent review of the Cochrane Library, which is displayed here. It was just published in January this year. And you can see that if you create some evidence for any type of tinnitus therapy, then in the first step, you will find counseling and cognitive behavioral therapy for tinnitus. What about pharmacological treatment? As I said before, there are some type of drugs which might be considered in certain situations. It needs to be clear that there is no drug approved for the treatment of chronic tinnitus, but we see some possible effects of clonazepam, acamprosate. And if you use it for comorbidities like depression, anxiety disorders, insomnia, headache, and so on, you might see that by improving that situation, you also improve the degree of suffering on tinnitus. Still, there are some compounds under development in terms of research, NMDA receptor antagonists, potassium channel modulators, and so on, and GABAergic substances, but they are still not available in terms of any approval by the agencies for general use. Here are some medication for comorbidities. It's just a small recommendation what to use in terms of tinnitus and depression. For example, citalopram, sertraline for tinnitus and insomnia. You can see that here, and recommended dosage of these medication, like trimipramine, mirtazapine, pregabalin. Anxiety and tinnitus, there is some good experience with opipramole and pregabalin. And if you have pain in the neck as well, then cyclobenzaprine might be an option. To be honest, I usually don't prescribe this medication myself. I'm very happy to work together with a psychiatrist who has a better knowledge on these different type of drugs, especially on the side effect portfolio. And so some otologists do it themselves, but usually I feel much more comfortable to have a psychiatrist with me who is then organizing that drug therapy in the special tinnitus situation. Last but not least, prevention is very important. The easiest way would be the avoidance of something for which there is no causal therapy. So avoidance of the occurrence of tinnitus is very important, and that's the reason why we need to work together as a society to create a better awareness, especially among young people, and to create an awareness that loud noise is dangerous for hearing loss and tinnitus, and that earplugs are helpful in avoiding too much noise exposure. I think this is one of the tasks we have as a whole society together, especially us otologists in the front. As I promised you, at the end of my talk, I would like to lose some words on tinnitus research, because I think it's very interesting. And you know, there is still a lack of therapy in the field of tinnitus. We don't have a causal therapy which really solves the problem for most of the patients. And that's the reason why we still look inside and want to create better therapies for tinnitus patients. Neuromodulation is a big topic. I will go into detail with that in the last slides. In terms of invasive and non-invasive neurostimulation, we have neurofeedback, bimodal stimulation. I will explain to you what is meant by that. New drug targets are under development. The help of smartphone applications is important for the ecological momentary assessment, and there's a new field of research in tinnitus management which helps the patient to improve his self-management in terms of smartphone applications. We need to better understand tinnitus, because as I told you, there are some models, but they explain not everything, and still there is a big heterogeneity. So probably we cannot compare one patient to another in terms of his tinnitus pathophysiology. We need to work together. We need big clinical databases on a national level, but also on an international level. If you just look inside your hospital and have a small group of tinnitus patients, you will not solve the problem yourself. So there is a big need of collaboration among countries, among societies, among disciplines. And still there's a lack of appropriate funding. If you compare the tinnitus field to the pain field, which has some similarities, then you will see that much more funding is inside the pain area as compared to the tinnitus area. So last few words on neuromodulation. What is neuromodulation? Neuromodulation refers to an emerging class of medical therapies that target the nervous system. And as you know, as I said before, the most evident problem for tinnitus is in the brain. So we need to target the brain to get better outcome in tinnitus therapy. And neuromodulation refers to the restoration of function, what we, for example, do with the cochlear implant. It helps sometimes in the relief of symptoms. We know it from the pain field. And of course, there are some similar models in between pain and tinnitus. It might be also helpful for the tinnitus field, and also for the control of symptoms. We know it works quite well, for example, in the Parkinson field for the control of tremor with a deep brain stimulation. And there's the idea, do we have something in the tinnitus field as well, that we place an electrode in the right place and then we get control of the tinnitus symptom. A little more in detail, neuromodulation therapy allows focused delivery of modifying agents, for example, electrical, optical, acoustical, or chemical signals, which are targeted to areas of the nervous system in order to improve neural function. To go into detail, neurostimulation is one part of neuromodulation. We can divide the field into repetitive transcranial magnetic stimulation. We have the idea that there is hyperactivity in the brain on the surface, for example, in the area of the auditory cortex. And so if we could deliver a electromagnetic field exactly to that location, which is delivered in a way that we can lower activity in the underlying brain tissue, it should be helpful for tinnitus. We have transcranial electrical stimulation in terms of different applications. You can see it displayed here. It's much easier because you just need 2 electrodes and then you can deliver electric currents in between these 2 electrodes. We have epidural brain stimulation as an option. You can see here an implanted electrode on the auditory cortex, on the dura above the auditory cortex. This is very experimental, but we have some studies which work with these interventions. And we have, as I said before, the deep brain stimulation, implanting electrodes deeply inside the brain, for example, in the thalamus. Other forms of brain stimulation and neuromodulation are vagus nerve stimulation, the neurofeedback, and different types of auditory stimulation. We talked before about cochlear implantation, about different specific types of auditory stimulation, which are called coordinated reset neurostimulation, where you stimulated frequencies above and below the tinnitus frequency. I talked about this earlier. For the field of tinnitus treatment with repetitive transcranial magnetic stimulation, we started in Germany in the early 2000s with 2 different labs and created in one lab a virtual lesion with high frequency stimulation of 10 Hertz. There we could create a temporary lesion in the auditory cortex, which was then followed by a transient tinnitus suppression in some subjects. And in another lab, in my lab in Regensburg, we had the low frequency approach with repetitive stimulation session over a long period of time of 2 weeks and could induce some long-term effects in terms of tinnitus suppression in some tinnitus sufferers. So the low frequency approach was more applied in the therapeutic intention and the high frequency more in a diagnostic intention. At the end, I go quicker over these slides now because I want to come to an end. This promising approach did not find its way into daily clinical practice. A multi-center trial randomized with 173 patients was not able to demonstrate the superiority of active over sham stimulation, unfortunately. Invasive brain stimulation can be delivered in terms of epidural brain stimulation, subdural brain stimulation, and deep brain stimulation. There are some ideas what could be done in the future in terms of invasive brain stimulation, focus on different areas. Right here, you can see here the caudate nucleus, areas in the thalamus, which can be targets in the future. But at the end, this is, of course, very, very invasive. You need to consider the complications of surgery, hardware failure, and stimulation-related side effects. So it can only be a last resort for really severely suffering tinnitus patients which would be open-minded according to deep brain stimulation. And it might be a situation that you do it for other indications. For example, you implant electrodes for Parkinson's patients and see effects in the tinnitus field as well. But at the end, I think it's limited to very less patients. Bimodal is quite a big hope for us in the future, I think, because there is an idea that if we combine auditory stimulation like here and stimulation of the neck with electrical currents like here, it might help in future. The same thing is with the vagus nerve stimulation, and something what is called the neuromod system is stimulating on the tongue with an electrical tongue stimulator, and additionally stimulating the auditory system, and the preliminary data of that technique showed really quite substantial reductions in tinnitus questionnaires. At the moment, it's in a confirmatory phase 3 trial, and the company is looking forward to FDA approval and things like that. I will skip the neurofeedback, which is a very low invasive thing and very hopeful in future. Who is interested can go into the literature, is something what my lab at the moment is investigating. And I think we will hear a lot of this in future. And at the end, I think for the neurostimulation for tinnitus treatment, we have only small size effects, mixed results, and are still not in a routine therapy with these things, especially with the transcranial magnetic stimulation and the direct current stimulation. And as I said before, the invasive stimulation in terms of implantation of electrodes is way too invasive for most of the patients. It's still experimental, and we have very limited data for that. There will be something in the future. Mobile therapy is an issue. You know that you might be able to do your neurostimulation at home. You plug your smartphone with an EEG cap, which you can wear at home, and then maybe able to do something like neurofeedback at home. We need to take care of the individual EEG rhythm in order to find individual type of neurostimulation, neuromodulation therapies. The combination of acoustic stimulation and neurostimulation might be interesting. So for the end, I summarize everything now, not only the research part. Currently, there is no cure for most forms of tinnitus, but the important message is that management of most of the tinnitus patients is possible and is working very well. Multidisciplinary approach is essential for diagnosis and therapy of tinnitus. The diagnosis of tinnitus involves a detailed case history, assessment of tinnitus severity, an ENT and audiologic examination, which is our core competence, of course. Other diagnostic procedures might accompany everything. Empathic and insightful counseling is very, very important. We have the specific topic of objective pulsatile tinnitus. This requires specific diagnostic assessment because we can do some very specific therapy in these cases, which sometimes really leads to no tinnitus at the end. The rest depends on further comorbidities. And if you find something which you can really treat, a specific pathology, then treat this. You should prioritize that. Treat hearing loss, treat a hole in the tympanic membrane, treat otosclerosis, and the patient might be happy for an improvement of his tinnitus as well. Symptomatic treatment involves cognitive behavioral therapy, hearing aids, and sound therapy, as I said before. Here are some key points at the very end. It's just summarizing what I said before. Tinnitus management in difficult cases should be performed in a multidisciplinary team. Look at all the available options around you and consider cognitive behavioral therapy for the really decompensated tinnitus combined with counseling treatment. Indication of pharmacological treatment is currently limited to specific tinnitus subtypes, for example, the comorbidities of depression, sleep, and anxiety disorders. And for the future, I think, based on a better understanding of the pathophysiological points of tinnitus development, there will be several new and innovative treatment approaches in the future in terms of drugs and neuromodulation, which are currently under clinical scientific evaluation. That's it from my side. Here's some additional literature, and I thank you very much and send you the best regards from Zurich. This is our hospital area right here. You see the mountains in the background and the lake in the foreground. So thank you very much for your attention.
Thank you very much. Really enjoyed the talk. There's Dr. Tobias, if you could look at the chat line, there's quite a few questions on the chat line.
Oh, where can I see the chat line?
The chat line on the menu, like next to share screens, there's a chat
so
icon.
I stopped the screen share now, sharing
yeah,
now? Okay.
Exactly.
Okay.
Yeah,
Here's the chat line. Okay.
yeah. So there's quite a few questions. But before, let me start by something you mentioned. Like initially, that you had to avoid catastrophic statements.
Yes.
About. Sometimes I find that catastrophic statements work. The patient, because if you tell the patient, listen, man, there's nothing for you to do here. You gotta forget about it.
Okay.
Can you agree?
It depends. Of course, I see a special selection of patients. They have been seen by several other doctors before until they reach me. And what they really sometimes tell me, that if somebody would have told it to me like you did now in the last 20, 30 minutes, it needs some time, then I think I would not have need to come to you. So I was told it's a bad thing. I cannot do anything about it. Please leave my office. There's no help. You need to take care of yourself, and there's no help from the outside. Of course, that's true for a certain point, but I think it needs some differentiation for the patient and some explanation. That's what I think should be usually done. So I try to avoid these things. And what is really bad if you talk about tumor and things like that, listen, there could be a brain tumor behind that problem, and this is really creating a lot of fear and anxiety from the side of the patient. And of course, in very rare cases, there can be a vestibular schwannoma. But to be honest, this is really a very special situation. And even if you find something like a small schwannoma, it's not a big deal. And also at that end, you don't have any, let's say, therapy which you can do after that, because you would not go for a surgery in a small schwannoma where you have quite a good amount of hearing left still, because you will lose your hearing and the tinnitus is still there. So it's even no option for therapy. So that's what I think should be clear.
Excellent. So can I ask you to pick up like 2 or 3 questions on the chat line? And we usually launch some polls. So if you see something splashing across your screen, don't worry about it. Just ignore it. But
Okay.
if you could pick up 2 or 3 questions from the chat line.
Okay, I can just, oh, and what is now here? What is your standard response to a 60-year-old with mild high-frequency hearing loss?
No,
not
this is
that
like,
one.
this is just polling. This is just polling. We ask people to like, because we are a community of like mature otolaryngologists. So I just wanted to get an impression of
Okay,
how people treat this. But if you could look at the chat line.
Okay, I go for this question. Do you have any hematological investigations for tinnitus? The colleague who is answering, or who is asking that, has an experience that he sees a lot of high cholesterol in tinnitus. Thyroid function test is a question. So to be honest, I don't do any lab investigations. I did a lot of that in the past, but I think there is nothing which really has a consequence at the end. Of course, if you look in big data, you might see some correlation of diabetes or high cholesterol and things like that with tinnitus. But I think the bigger problem is not the high cholesterol, it's the hearing loss, which usually leads to the tinnitus perception. And I don't think just ordinary hematological investigation have any consequence in a therapeutic situation. And I don't use it for counseling. No, I don't.
Even if you have like a lady pulsatile tinnitus, you're worried about anemia and stuff?
That's a different situation. So I would go for I would answer this question for the chronic subjective type of tinnitus. If you have an objective situation, of course, it might be interesting to know something about the hemoglobin, or to know something about the blood pressure and things like that. That's true, but not in other situations. There might be some specific situations. If somebody tells you, okay, this tinnitus occurred after a tick bite or things like that, of course, then you might go for into detail for Lyme's disease or things like that. But in the very ordinary standard situation, I don't think there is a place for hematological investigations. You can lose a lot of money with that. That's my idea to that. There's a question. You mentioned that even in the case of nerve dissection, the tinnitus doesn't disappear. So why it's getting better with hearing aid and cochlear implantation? Okay, very difficult question. So there was a publication in the 70s, I think, from the House Institute in Los Angeles that they did some nerve dissections for very bad tinnitus patients. So in patients which really had a very bad hearing on one side and tinnitus on the same side, and they thought, okay, why not cut the connection in between the ear and the brain and cut the nerve, but the tinnitus was still there. And that's the same thing what we know from vestibular schwannoma surgery, that in cases where you really need to remove the tumor and usually need to cut the nerve, especially, of course, the vestibular part, but sometimes even the auditory part of the nerve, that the hearing is gone after that and the tinnitus persists, which is a clear sign that the tinnitus perception has something to do with central nerve activity in the brain. The reason why hearing aid and cochlear implantation are working, especially for the field of cochlear implantation, is not that clear for me. But usually in the field of cochlear implantation, you need a intact nerve. Otherwise, of course, the cochlear implant doesn't work, and it's a clear deep predisposition that you need the nerve intact. Otherwise, the cochlear implant is not working. And I think the major improvement of these enhanced auditory situation comes from the masking effect of the hearing aid. So the better you hear, the less you hear what's going on in your brain. For cochlear implantation, it's not clear. It's quite a phenomenon that in most of the cochlear implant recipients, really tinnitus gets better after the active implant. So 4 weeks after surgery, the implant is activated. And one of the first thing the patients are reporting is that, okay, tinnitus, I don't hear it anymore, even if they don't get used very much to hear with the implant. So there must be something which is related to the electrical stimulation of the implant. And this, of course, leads to a completely new field. And there were some attempts to use the electrical stimulation and implant an electrode on the round window, even in people which have quite good hearing. But at the end, it's not that good like the implanted electrode in the cochlea. So it's an open field, and not everything is known about that effect. I would be happy to know more about it, because I would be really happy to transfer the effect of cochlear implants to all tinnitus patients, and even those which hear very well. But again, probably tinnitus is very heterogeneous, and a patient who has no hearing on one ear and tinnitus on that ear is probably different to a patient who has a normal hearing or age-related hearing loss and tinnitus. So it's hard to transfer this knowledge so far, but maybe future brings something else.
Is there any data on hybrid implants? Do they work the same way as the cochlear implants work?
You mean the electric acoustic stimulation?
Yeah, for
where you have the
tinnitus.
hearing, where you have the hearing aid and the cochlear implant. Yeah, I think it works in the same way. It works good.
Okay, all right. And any data, by the way, on people like, say, prelingually deafened people or severe sensory neural hearing loss? Do they have tinnitus?
Yeah, very good question. I think no. I think it's something which develops during time. I think there's not very good data on that. So you mean, for example, kids who are born deaf?
Born or severe to profound hearing loss.
I'm not aware of very good data in that issue, but I think tinnitus is really something which you develop during time, which is not there from the beginning, and which usually comes as a feature of neuroplasticity in the brain, that the brain is adapting to either sudden loss of hearing or the slow loss of hearing over time.
All right. So we launched just want to show you the results of our polling of this is, again, most of us are mature ENT surgeons. So again, like about 52% say, get on with your life. There's no to the patients that there's no treatment for tinnitus.
Yeah. Okay. I would go with the majority of that people. Of course, you need to specify a little more. If this is really mild, high frequency hearing loss, which is not able to be amplified with a hearing aid, I would go for that. Of course, it depends on the degree of suffering. If somebody says, okay, there's some tinnitus, but usually I can sleep and I can do my usually work and I can concentrate, then I think some counseling would be good about how tinnitus is working, and then I'm fine with that. I would not do an MRI scan or other workup. As I said before, MRI is only something which I use in the asymmetric situation of tinnitus, or in the pulsatile type of tinnitus, but not as a standard workup. Masking devices, I don't think it's really needed in the compensated situation. Maybe to fall in sleep and to get the distraction in the very silent situations away from the tinnitus to any other more comfortable sound. And the psychologist probably in a situation which is not decompensated is not necessary.
That's great. Thank you very, very much, and really enjoyed the talk. And thank you for taking an hour of your time to be with us. Thank you.
You are very much welcome, and I hope that most of you could follow everything. It was not too fast and not too much information. I'm happy to do it, and I'm happy to talk again if you have any need about these.
Great.
Okay.
Thank you, Dr. Tobias. All right.
Thank you very much.
Take care.
Bye-bye.
So thank you, guys. Bye-bye. Yeah.
Bye-bye.
Take care. So thank you again, guys. And, you could follow the schedule, and we're adding quite a few sessions for our future efforts. So have a nice evening. Take care. Bye-bye.
Bye-bye.